Welcome to today's webinar brought to you by GrassrootsHealth. Thank you everyone for attending and submitting your questions. We will be addressing questions after the presentation with Dr. Susan Whiting. For those of you who have questions about individual dosing, we have this chart on the grassrootshealth.net website, and we encourage you to refer to this chart on the homepage to help you determine what dose might be best for you based on your current and desired vitamin D serum levels. And with that, I would like to welcome Dr. Susan Whiting. Hi, Dr. Whiting. Thank you so much for being with us today.
It's my pleasure to be here. And I'm addressing vitamin D mainly from a public health perspective initially, but I know when we get into the question and answer, there'll be plenty of discussion about individuals and what to do. But we just received some disturbing news in the last couple of weeks, and that is that our vitamin D levels in Canada have been going down. And this can only result in more pain, more cost to the healthcare system. So I'm going to address some of the public health side of vitamin D, what's being done at the government level for the population, but also we'll be talking somewhat about many of the factors that are affecting our vitamin D levels and what we can do about them. I've only chosen 5 slides to illustrate this, and hopefully it has implications for both my country, Canada, as well as the United States and many other countries around the world. We have always thought that vitamin D was a disease or a condition, the deficiency was a condition resulting from geography, but we now know that lifestyle and other factors are also affecting our levels. So if we look at the first slide, we're going to see this trend that has us somewhat perplexed and worried. Here we are, and we're illustrating in this graph 2 surveys that have been done in Canada. These are called the Canadian Health Measures Survey and labeled Cycle 1 and Cycle 2. So the more recent one that was just released is called Cycle 2. And it is shown in the red bars. And what we're seeing is the percent of the population in Canada that is below a cutoff of 50 nanomoles per liter. Now, 50 nanomoles per liter, which is 20 nanograms per mil, is a very low and conservative level that was set by the Institute of Medicine for Canada and the United States to use when we're assessing vitamin D levels. And although we're not recommending this level ourselves, it is an indication of the health of the nation. And what we found for Cycle 1, which was done between 2007 and 2009, was about a quarter of our population was below this cutoff. And that indicates vitamin D deficiency. In the intervening years, there's been a number of initiatives and certainly more interest by the population in improving vitamin D status. Therefore, it was a surprise to us when the new cycle was released, indicating that almost 1/3 of the population was now below this cutoff. So it means that we really have to work much harder in order to improve the vitamin D situation in our country, and this would be applicable also to other countries, including the U.S. Now, in the next slide, the factors affecting vitamin D status of Canadians is illustrated, and I want to show this slide to indicate what it takes to understand these national data and what it took for us to convince our government that we really did have a vitamin D problem. And how I'm illustrating that is going from the left-hand arrow to the right-hand arrow. So the left-hand arrow is showing that Canadians year-round had this 26% deficiency problem that was recognized But the government at the time didn't think that this was such a high value, and that the vitamin D deficiency problem was somewhat overblown. And we had a lot of rhetoric around that in 2010, 2011, when the new Institute of Medicine recommendations were released. However, we wanted to show the government and show other policymakers that this level was really an underestimate of the true situation that was going on. And how we did this was, first of all, indicating that, especially in Canada, we only make vitamin D 6 months of the year. So we should be looking at how our levels are in the winter. Secondly, we should be considering whether or not at the time the Canadians that were being evaluated were taking a supplement or not. And thirdly, we need to consider some of the population for whom the synthesis of vitamin D from the sun is severely compromised. And those are in those participants who categorize themselves as non-white. These would be our Indigenous population and many of the immigrants who have come to live in Canada. So when we teased away the seasonal effect, the ethnicity, which is a reflection of how well sun exposure will work, and supplement use, we ended up with the right-hand arrow at 60%. And certainly the government is listening. There's not as much activity as we would like, but has now listened to the fact that vitamin D is a problem for Canadians and something that needs to be addressed. Now the next slide shows one reason why our levels aren't as optimal, anywhere optimal as they should be, and that is where we examine the amount of vitamin D available in the food supply. This was done through an extensive analysis of intakes of Canadians, similar to what is also being done in the United States. And here we're showing that despite differences in age and sex, and essentially body size and dietary characteristics, our diet provides on average only 200 international units a day. And this is well below the level of 600 IUs, which is now set as our RDA, and that RDA is set to achieve that 20 nanogram per mil level that the Institute of Medicine has sort of thrust upon us as our cutoff level. So all of this is a very conservative approach to how much vitamin D is needed. But the point we had to make to our policymakers and to ourselves and others is that the food supply is severely lacking in vitamin D, and it is not possible, despite the rhetoric that we heard, for someone to choose foods that could meet the amount of vitamin D that's needed every day. Now we know that there are other ways to get vitamin D. We can get vitamin D through sun exposure, and I'll be addressing this later because many of the questions were asking about that. But the short answer for Canada is we only have 6 months of the year where sun exposure is even possible. The ultraviolet B radiation that's needed is not. The sun is at such a low level in the sky between October and April that we cannot make the vitamin D that we need. So really we do want to spend a bit more time on looking for dietary possibilities. And we're seeing that food and fortified foods may not be the answer. However, fortification is a way for a whole population to attain the vitamin D that they could have, and we use it in, for example, with folic acid. So the next slide is illustrating that there are some fortification new foods that are on the marketplace. But one of the things that has perturbed us is the fact that these foods contain very little vitamin D per serving. And so to attain even 400 IUs from these new fortified foods on the marketplace, as well as some that were already there, such as milk, a very large serving is required and at a fairly high cost to the consumer. So 400 IUs, which would bridge the gap between our current intake of 200 and our RDA of 600, is not really feasible in today's marketplace. And we certainly don't expect consumers to consume 10 slices of cheese or 4 to 8 eggs a day in order to achieve their vitamin D. So it's an important message that we have to send, that while we want our food supply to be improved, it's not at a state right now that we can tell people that they can achieve vitamin D, adequate vitamin D status through foods. And in essence, I think that our government and our government agencies have abandoned the population to come up with their own solution to vitamin D, because they have not promoted the use of supplements in any of the in the literature that we get from them. So that leads us to the next slide. And here we have an illustration of what could happen. This is a study that was conducted with Bill Grant, who many of you may know. He gave the last webinar. And along with some Canadians, including myself, we examined the state of vitamin D in our country, and we examined the risk of various diseases that were known to be affected by low vitamin D status, and making the proposal of raising the level of 25-hydroxy-D, the vitamin D metabolite that we measure for status, from the current levels that were reported in our Canadian Health Measures Survey to the level of 100 nanomoles per liter, or more commonly known as 40 nanograms per mil, that if we could do this on a countrywide basis, we could save our healthcare by $14.5 billion. And what is illustrated here are the major disease states that are affected by a low vitamin D status. And foremost are cancer and cardiovascular disease. And certainly viewers of this webinar have seen many of the evidence for reducing the risk of cancer that vitamin D can have. There is also evidence for cardiovascular disease, especially related to blood pressure, diabetes mellitus, multiple sclerosis, musculoskeletal diseases, influenza, and pregnancy and birth complications. So these are the many diseases that have vitamin D as vitamin D deficiency as a risk factor. And by bringing the level of the country up to 40 nanograms per mil would reduce the risk of these diseases to the extent of saving healthcare. Now, it may seem rather cynical to people that we're talking about money, but we're using money to illustrate that by approaching the government and making this argument, we are improving the quality of life of the people in the country. So without adequate food supply with vitamin D, supplementation is really the only way we are going to address this problem. Now, many of you have submitted questions related to what the levels of vitamin D should be and the amount of vitamin D that would attain it. Grassroots Health has provided the table and indicated that in order to achieve vitamin D levels that are recommended, then the suggested IU should be followed. Now, the first question.
Thank you again for the presentation. And I'll go ahead and ask the questions, and then we'll look forward to an answer. So the first question, the first question, what is your recommendation, or what is the recommended blood level of vitamin D for subgroups of children and adults? What levels of supplementation do you recommend for each age subgroup?
Generally speaking, all of us need the same level. That is, there's really no particular age group for whom vitamin D has a greater or less risk. We've tended in the past to focus on elderly, and they're certainly a high-risk group, but we now know that through pregnancy, lactation, infancy, we all should be achieving the level of 40 nanograms per mil. Therefore, one would have to adjust, though, the intake of vitamin D to achieve it, because it's going to be different based on different body size and body composition. So I think what one should do is start with the recommended levels and then have them tested to make sure that they are effective.
Okay, and hopefully that's better for everybody now. On to our next question. What is your recommendation for an optimal level for prevention of diseases?
This is the level that GrassrootsHealth is promoting, 40 to 60 nanograms per mil. That is the optimal level, and evidence is out there suggesting that it works. Most studies are looking at people who are deficient, and when you take them out of deficiency and even improve their levels above 30, you begin to see effects. But optimally, it should be up to 40 to 60.
Thank you. Can you take too much vitamin D? What is too high, and what are the risks of it being too high?
Well, this is a good question, because sometimes people forget about the fact that many things are dangerous in high amounts. Almost every nutrient is needed in the body but can be dangerous at high amounts, and it's not surprising that vitamin D is one of those. So it really does not do a person more have more benefit to take very high doses. And so it's important to look at the schedule that Grassroots Health provides, take that level, and then have it tested after several months to make sure that the levels are within optimal but are not exceeding anything. Vitamin D has an effect on calcium metabolism, and so when levels are very high, there's a risk of calcifying tissues in the body, and therefore causing possibly cardiovascular or renal diseases because of that. So it is important not to think that more is better in this case.
What is the optimal serum level of vitamin D? I think we just touched on that, but it appears that for some risk factors, such as the risk of breast cancer, the risk declines more as serum levels higher than those previously recommended. Is there a higher level that a concerned individual might target?
Well, this question addresses risk. Someone who has a greater risk of a disease probably should pay much more attention to their vitamin D level than someone who is using vitamin D along with many other healthy lifestyle factors. Someone with a risk should make sure that they are taking the optimal amount, have their levels tested perhaps more often, and may even consider higher levels as long as it's being monitored by a health professional at the same time. What we call this is risk-benefit. You are assuming perhaps more risk by taking a higher dose or achieving a higher serum level, with the hope that there is greater benefit for whatever disease you are working with. And this is not when people are faced with some sort of devastating disease. So I think that we need to divide our thinking between people who just want to lead a healthy lifestyle and make sure their vitamin D is adequate and in particular optimal for them, versus someone who has a disease condition and is wanting to use vitamin D in a way that could possibly have some therapeutic benefit. And that would be using higher doses but being monitored more closely.
Why is there such debate about what is an appropriate optimal vitamin D level? Why wouldn't all researchers agree to look at the 25 OHD level in people at the equator who get lots of sun to determine the optimal target?
Well, this is probably, the answer to this question may surprise people. We actually never really knew what the 25-hydroxy-D level at people at the equator was until a paper was published last year in the British Journal of Nutrition. And they assessed a population in East Africa who were living a more traditional lifestyle. These were people who just went about their business. They didn't stay in the sun when they didn't need to. And they published their 25-hydroxy-D level of 115 nanomoles. So that's over 40 nanograms per mil. And that suggests that that is a natural amount of vitamin D that is attainable through sun exposure in a place in the world where there would be no dietary sources of vitamin D to depend on. So that's fairly recent information, and I think that we can all now put to rest the idea that we should be surviving or living with lower levels of vitamin D than that. But as I said, it was really just published last year, and so it's something that we can all consider. The debate, though, goes farther than that, and it addresses the biases that many of us, and I'll put myself in that category, many of us have when we examine lifestyle trends. And that is that we forget to look at a whole range of factors that might be affecting it. And in the case of vitamin D, we really hadn't noticed that our dietary sources were limited and that our lifestyle was taking us more and more indoors. So as we study the equatorial regions of the world, look at shifting work patterns, look at people who, instead of working out in the fields to bring in crops, are now working in factories 6 to 7 days a week, we are beginning to understand what a devastating problem vitamin D deficiency is becoming.
Right. Question 6. When should we request testing? Are there any symptoms we should look for? And what is the most accurate test or indicator?
One really doesn't have symptoms of low vitamin D. One of the reasons we focused on the elderly for so long was that their muscle strength, their balance, and their propensity to fracture was much more obvious. But really, vitamin D deficiency doesn't necessarily show up. It can be a feeling of, for some people, malaise. There's an association with depression in some people, tendency to get colds and flus, but really there's nothing that we can pin on vitamin D deficiency. So we actually all require testing. This is something that certainly for those of us in Canada has been commented on, and many provinces will not allow routine testing for no reason. Their answer actually is that you're likely deficient unless you've already begun taking a supplement. So why would we bother to test you for something we already know you have? Seems a little illogical, but that's been the statement that's been issued. So all of us could be tested at some time. It's a very illuminating experience to know, to think on one hand that you might be adequate in vitamin D and find out that you aren't, or that perhaps this very low level of vitamin D that you have is causing some of the symptoms you might be feeling, but these are quite nonspecific and don't necessarily lead you to testing. So the bottom line is everyone should be tested. Whether or not your health provider will pay for it is another question. And the most accurate test is the 25-hydroxy-D that is done by various means, but as long as you realize there's some variability in the answer, it can pinpoint your level to the extent that you'll know how much vitamin D you need to either improve on that level or to stay at that level.
And just to put this out there for everybody listening in, Dr. Robert Haney will be addressing this particular topic next week. Question 7. How do we determine the cause of low vitamin D? A course of action considering everyone's uniqueness. And when is retesting appropriate? at a specific time or no change in symptoms?
Well, what we're finding in our national surveys is almost all of us are below 40 nanograms per mil. And the reason is that we lack sun exposure and dietary sources. So unless a person is having sun exposure through work or is already taking supplements at the doses that would impact their level of 25-hydroxy-D, we're all low. So one can look at one's own lifestyle and figure out that you work indoors and the food choices that you have don't include any of the fortified foods that are currently on the market or fish. But it's not about really blaming any particular situation. It's about acknowledging that with our current lifestyle, and we're not nomads in East Africa, then our levels of vitamin D are likely inadequate and we need to do something about them. The retesting is usually done at least a month or two after the initiation of a supplement regimen. If you test too soon, you haven't allowed the body time to build up its stores. But if you test too late and you're not taking the right amount of supplement, then you could be missing out on achieving that optimal vitamin D. Right now, by joining GrassrootsHealth, one can get vitamin D testing done every 6 months, and that seems to be fairly appropriate because you're able to monitor how things are going. But if there's any other reason why someone is concerned about their vitamin D level, the testing would have to be done more frequently.
Right. Is there natural over-the-counter vitamin D, one that is not made by Big Pharma? I've been getting my D through sunshine and cod liver oil.
Well, the person asking this question, it's hard to know if they really are getting enough vitamin D through sunshine because it depends where they live. It depends the nature of the clothing they wear, because it's not hands and face. It's really having legs and arms exposed to the sun, but not necessarily for a long period of time. But it depends on really the latitude and other situations. What disturbed me about this question, though, was the fact that their source of vitamin D is cod liver oil. Cod liver oil is a poor source of vitamin D for several reasons. If you carefully read the label, you will see that the amount of vitamin D in most cod liver oils is only, in some products I've seen, 100 international units to 400 international units. So the amount is small. But we would not suggest that you take more of it, because what is coming along with that vitamin D is vitamin A. And the amount of vitamin A in cod liver oil is actually high. So by attempting to reach an optimal amount of vitamin D through cod liver oil, you will get vitamin A toxicity. So it is not a good choice. What one needs is a supplement. There's many out there. Actually, many small companies came into the marketplace to fill the void because Big Pharma actually wasn't providing the vitamin D supplements that consumers requested. And if you go on trusted websites like the Vitamin D Council, you'll find some suggestions for different products. But these are the ones you need to take, and not cod liver oil.
Okay, thank you again, Dr. Whiting. And we have reached our 30-minute mark. However, Dr. Whiting has agreed to stay on for some additional time to answer more questions. Anyone in the audience can remain in the webinar for these additional questions if you choose. Just to close out our 30-minute session, please tune in next week for Dr. Robert Haney. He will be speaking on why test vitamin D. And if you haven't already, visit our website at grassrootshealth.net to order your vitamin D test kit, and in doing so, you'll be joining the D Action program. And this recording will be posted on our website, along with the additional question and answer session that we will be beginning in just a second, under the videos tab. So let's get back to those additional questions that we've had. You can see we have a lot to cover still, so on to the next. Question 9. I have heard that vitamin D3, in order to be effective in preventing osteoporosis, must be taken together with K2, especially in their form MK7. But what is strange to me is that some advise taking 200 micrograms of K2 for every 1,000 IU of vitamin D3. What would you suggest?
This advice of taking this additional vitamin K2 really just came out in the past few months, and there's no published evidence to support it. So it is something that is being promoted, but without the evidence to substantiate it. None of the trials that have shown that vitamin D is effective in fracture prevention employed a vitamin K2 supplement. One of the things, though, that we might want to consider is vitamin K2 is a form of vitamin K that can be made in our own intestinal tract, but it would require a person to have good gut function. And so, consuming probiotics and having a healthy diet would certainly promote that. Currently, there's research going on about vitamin K2, but there is no consensus that it by itself is needed along with vitamin D. We do promote the idea that you need all nutrients to be healthy, and we don't necessarily want to focus only on one, for example, vitamin D. So it is important to have a healthy diet. It is important to get vitamin K through diet, and vitamin K can be obtained through plants as vitamin K1 or through fermented foods as vitamin K2. So we certainly would promote people ensuring that their overall diet is healthy, but there's no currently any evidence to suggest that 200 micrograms of K2 is needed for every 1,000 IU.
Question 10. What is the best way to take vitamin D? Timing with what other nutrients, with meals and fat, any foods or prescriptions to avoid with vitamin D?
Well, vitamin D is a fat-soluble vitamin. It does help to have some fat with it. There's a small amount of fat present in the tablets that you take, and those of you who use vitamin D drops, those drops are suspended in a small amount of oil. So they have been shown to be effective in delivering the vitamin D that you need. However, there was a small study published last year that showed that subjects who were asked to take vitamin D, their levels didn't rise well, and they went back to these subjects and had them take their supplements with meals, and then the levels did rise, indicating that for at least some people, taking vitamin D supplements with food might be a good idea. There's no time of day, however, that is when vitamin D should be taken. So if you're going to take it with a meal, it can be whichever meal is best for you and will help you remember to take your supplement. There are various prescriptions that will affect your vitamin D status. These need to be discussed with your doctor, but there are certain drugs that you may be taking, such as anticonvulsants, glucocorticoids, some of the AIDS drugs, anti-rejection medications, to name a few, that may impact your vitamin D status. And so you may need to take more vitamin D or vitamin D at a different time when using these particular medications. There's no known foods that will impact adversely the vitamin D that you're consuming. And as I mentioned, it might be a good idea to take vitamin D with a bit of food just to promote its absorption.
Okay, and the next question, you answered the first part, but what about applying it to the skin or the gums or under the tongue?
Well, there are some people who have malabsorption problems, and they do find taking oral supplements of vitamin D are a problem. And usually this is solved by just taking a higher dose to ensure that enough is absorbed. And so for some of these people, supplementation might actually have to be augmented with ultraviolet B radiation at various times to make vitamin D rather than to rely on a supplemental form. I know of no successful studies showing that skin application or gums and tongue work or certainly work any better than oral supplements. So for now, unless you have a malabsorption problem and are needing to have additional supplements or ultraviolet B radiation to ensure skin synthesis, then oral supplements are fine.
Okay. Can vitamin D raise an individual's HDL level?
I think this question is really asking, does it have benefits to cardiovascular disease? Because, you know, the common thinking is we want to have higher HDL levels. None of the studies that I have read show an impact of vitamin D on HDL. It does seem to have a positive impact on cardiovascular, and it may be more through blood pressure than through blood lipids. So don't think that just because it doesn't have an effect here that it doesn't have an overall effect on cardiovascular.
Okay. Is there anyone that should not take vitamin D supplements?
There is a group of individuals who have a particular disease that causes them to overproduce the active form of vitamin D. And for these individuals, they need to have their vitamin D intakes monitored very carefully. But this is a small group of people with a particular problem, and it doesn't affect most of the population. However, there have been websites devoted to this particular disease that have made general assumptions that no one should take a vitamin D supplement. So it is true that a very small portion of the group, and they can have their condition tested because their blood levels of the active form of vitamin D actually get very high and need to be treated separately.
What would one wear to expose 40% of the skin to get vitamin D from the sun in 10 minutes? We talk about getting sun from UVB and 10 to 15 minutes is usually okay. What percentage of the skin is exposed when wearing short sleeves and long pants?
This question is addressing the fact that when you make vitamin D in the skin, you make it all over your skin. And that if you want to maximize the amount of vitamin D made through skin, you have to have that skin exposed to the sun. And it's therefore not enough to expose hands and face, which is really maybe 10 or 15% of your body surface when vitamin D is being made through the sun. 40% is a value that you would have if you wore sort of a tank top and shorts. And your arms and legs are exposed to the sun. And in a very few minutes, for some people, you would be making thousands of international units of vitamin D. The second question about wearing short sleeves and long pants, now you're only exposing about 20% of your body surface area to sun, and that really isn't very much. The study I mentioned from East Africa, people are wearing just very modest amounts of clothing, and while they're not intentionally standing in the sun to get sun exposure, just through their normal everyday activities, they're able to make vitamin D from this additional skin exposure. So we have a problem when people recommend a small amount of sun exposure. They often don't indicate that you need to be having arms and legs and even a part of your trunk exposed to to get that maximal vitamin D made. And most of us just aren't walking around wearing this type of clothing most of the time. So that's one of the reasons why vitamin D, low levels of vitamin D are now commonly seen.
And Susan, real quick, going back to the previous question, what is the name of the disease that you were mentioning?
It's a granulomous disease, and one of the conditions is called sarcoidosis. And these individuals usually manifest with problems early in life and are then tested for the presence of the active vitamin D. And they often are recommended to avoid sun exposure and to avoid vitamin D. But they have to be managed very carefully, so they wouldn't fall under our normal guidelines for supplementation.
And they would know very early in life that they have this issue.
Right.
Okay, so question 15. We touched on some of it already. Very quickly, can you touch on the risk of getting skin cancer as well as getting sun in winter versus summer?
Well, the first thing I want to address is the idea of laying in the sun. I don't think that's a good idea, and none of us are promoting sun tanning out on the beach as a way to get vitamin D. What we're normally talking about is the fact that people should feel that they can be out in the sun, gardening or doing something, taking a walk, in which they are getting what we call casual sun exposure. But the timing is not an easy question to answer because it depends on your level of skin pigmentation. So let's assume that we're all wearing shorts and a t-shirt. A person with very light skin really should only be out in the sun for possibly less than 5 minutes because they've made all the vitamin D they're going to make, and at that point they're risking the ultraviolet rays, both A and B, to promote skin cancer. And those people generally know that their time in the sun is severely limited. However, someone with much darker skin pigmentation needs a longer time to make vitamin D, and therefore can spend more time. There is a chart available in one of the publications by authors Webb and Engelson, and this paper is cited in many vitamin D articles that have been published over the years. And they chart out the time that would be needed for various skin pigmentation types. And the bottom line is you want to be in the sun without burning, because once you're burning, you're not making vitamin D at all. And for many people, the amount of time is actually quite short. So it's just to reiterate, it's not lying in the sun to make vitamin D, but having that sun exposure through daily activities is a natural and normal way to make vitamin D.
And then is there any way to know if somebody would be better off getting the vitamin D from sun exposure versus taking supplements?
Right now we see no advantage to getting vitamin D exclusively by sun exposure. I think that, as I've mentioned, you need to have to be wearing, less clothing, and you would need to know the amount of time best suited for your own skin type. And these are factors that are difficult to give. They're available in literature, but they're not easily. I can't just say, oh, you need 5 minutes. So it's, as I've mentioned, this study in East Africa, those people are just going about their everyday activities and achieving a vitamin D level that is between 40 and 60, and they're doing it, we think, by safe sun exposure because they have pigmentation that does protect their skin during the day. So we're suggesting that the easiest way and the most sort of reliable way is to take supplemental vitamin D and then have yourself tested after several months to make sure that it's working for you.
I worked outside for a year and a half, but tested at 19. Why do I not make D?
Well, working outside can be an advantage, but it depends where and how you're working outside. And if you're a construction worker wearing long sleeves, jeans, and a safety hat and boots, you have very little of your skin exposed to make vitamin D. Similarly, if you're working outside in a country like Canada, for 6 months we don't have any ultraviolet B radiation from the months of October to April. So that's not going to help either. So part of the answer is really being out in the sun in today's, the way we work today, where we wear clothing for work, for safety purposes. We really can't count on that level of exposure. So this individual may really not have had much skin exposed to the sun to make the vitamin D that he needed. So it's good that he got tested and he wasn't assuming that that sun exposure was helping him, and now he can take a supplement that will bring his level up to 40.
Right. What would be an optimal level for someone with osteopenia and in menopause? Personally, I don't feel that a level of 50 is adequate to address these issues. Also, with a good level of vitamin D, what level of calcium do you recommend for menopausal women?
Well, this is going to depend on whether this is an American or Canadian caller, but 50 nanograms per mil is fine. I'm not sure what the reason would be why this person would feel 50 was inadequate. However, if they're addressing Institute of Medicine's value of 50 nanomoles per liter, then we're in agreement, and 50 measured in those units isn't sufficient. So here's one of our problems that we have in dealing with vitamin D is this unit that are used in different countries and therefore causing a lot of confusion. So 50 nanograms per mil is good, 50 nanomoles per liter is, I would agree, inadequate. Once your levels of vitamin D are adequate, then your absorption of calcium is improved. We currently have recommendations for calcium that are 1,000 to 1,200, and now we're finding that through various studies, excess calcium may be causing problems. For example, kidney stones or possibly cardiovascular. So it is not necessary to overdose or to be too aggressive with the amount of calcium that you're taking. It's important to know how much you're getting in the diet and only add a supplement if this is not reaching that 1,000 to 1,200 milligram range. Now remember that 10 years ago we were talking about high calcium and vitamin D was rarely mentioned with osteoporosis, and this thinking has now changed. So don't consult old textbooks, old articles, but read the most recent guidelines to get this information.
Right. And again, Dr. Whiting, I want to thank you. I know that we're running close to the end of our time, and I know we have a lot more questions to address, so I wanted to just offer you the opportunity to close with a last statement or addressing one last topic.
Well, I think what I want to assure people is that there is a lot of confusion out there about levels of vitamin D, about amounts of vitamin D, about cutoffs, and what we should be doing. That many of us are trying to dispel some of the attitudes and biases about vitamin D, and I want to commend GrassrootsHealth for really being proactive in doing this. I go on the internet and I read these questions and various other comments, and I know that we have a long way to go before we can really provide consistent and accurate information. So if people just need to choose a very dependable source for their information and realize that we're all learning, and that as the new science is coming out, we're beginning to understand better what we can do with vitamin D. But in the meantime, it's really an individual's requirement to have their own levels tested and to make sure that they're getting what is the amount that's doing them the most good.
Okay, well, thanks again, Dr. Whiting. It was a pleasure to have you on today. And thank you to the audience as well for your time this morning. We're going to close now, but please remember to tune in next week for Dr. Robert Haney on why test for vitamin D. You can register now for Dr. Haney's webinar at grassrootshealth.net/webinars. And if you haven't already, visit our website, grassrootshealth.net. And you can download any of these past webinars, as well as some helpful charts and graphs that we have on vitamin D. And you can view a recording of this webinar as well, again, under our videos tab. Looking forward to having you join us next week. And Dr. Whiting, thanks again.
Okay, thank you.
Have a good day.